Okay, can you hear me?
Yeah, I can hear you. Please start your screen share, sir.
Okay, I will share my screen.
And welcome.
Can you see it?
Yes, please. Yes. Can you enlarge it, please?
Okay. Thank you for your invitation. I'm Dr. Zhang Wei from China. Today's
Cara itu sharing itunya gimana? Sharing screen dari sini atau dari sini?
Today's topic is third portal of the UBE. The content includes a lumbar URBD, Jones portal, and lumbar quarterback key portal, and a double cage insertion by Jones portal and quarterback cage insertion portal, and the cervical URBD by the third portal and the cervical quarterback key portal. Jones portal is a contralateral portal. Its indication include first is easy to do the decompression of the contralateral side. The next is suit for the complex spondylolysis and to get more autografts for the fusion case. And it is easy to insert the second cage by the contralateral third portal. And for the full decompression of contralateral side when we perform cervical UBE and URBD. You can see the left side is ipsilateral view portal and work portal, and the Jones portal is contralateral side work portal. How to locate the Jones portal? I think is the mirror position of the ipsilateral work portal. First, I use the tip of the knife to locate the position of the Jones portal. Then I insert the first guide rod under the monitor of the endoscopy. This is endoscopy and IF and the first rod through the contralateral portal. You can use the endoscopy to monitor the whole procedure of the building the contralateral side portal. This is the contralateral IEP, and this is the inferior spinal process. We insert the guide rod through this narrow area. This video shows how to build the contralateral portal. First, we build the portal. Then we insert the IF to clear the soft tissue, and I use the calcium punch to do the decompression of the contralateral side. The angle is very good, so it's easier to use the calcium punch through the contralateral portal. You can see the contralateral side, the upper margin of the laminar and the corner. We also can use the IF to control the bleeding. This is the corner area of the contralateral side. The facet joint. If we choose the apsilateral portal, it's difficult for us to do the decompression of especially the upper margin of the lamina. You can see the medial wall of the pedicle, and we insert the tube through the contralateral portal. And the decompression area include the contralateral, the upper margin of the lamina, and the corner, and the medial margin of the SAP. We also can insert the cage through the contralateral portal. This is a trial cage trial. So we insert the reamer through the Johnson portal, and we can see the trial. This video shows how to insert two double cage through the apsilateral side and the contralateral side. This is left is the cranial, right is the caudal side, above is the middle, below is the surgeon side. We use the RF produced by Bones Company to clear the soft tissue in the interlaminar area. We can see the IEP, the lower margin of the lamina. This case is in the L4 and 5 level. We can see the laminar of the L5. Yeah, this is the laminar of L5 on the surface of the L5 laminar. We do the bone work from the basement of the spinal process. Now we found the insertion of the flexible ligament. This is the color. We can see the contralateral side, the flexible ligament, and the apsilateral side flexible ligament. We remove the bone of the basement of the spinal process to get the enough space for the work on the other side. We use osteotomy to remove the IEP from the inferior part. This is the apsilateral corner area. It formed the upper margin of the laminar and the medial margin of the SAP. This is important anatomy. Under the corner, we can find the nerve root. The blood vessel band from pedicle to the foraminal area. This is the medial wall of the pedicle. And L5, the nerve root. We open the annular fibrous, and we make a window. We can use the radio frequency to open this area and insert the reamer to deal with the disc space. You can see the end plate. Insert the detectable cage trial. Then I test the remaining portion of the SAP. Then we build the third Zhang portal. You can see the contralateral side IEP and interlaminar area. The left side is IEP. The right side is the spinal process. We remove the contralateral IEP. We can see the contralateral side, the surface of the SAP. Then we do the decompression of the medial margin and the corner and the upper margin of the laminar of the contralateral side. We open the annular fibrosis of the contralateral side through the Zhang's portal. Then we insert the we deal with the disc space and and insert the reamer. The whole procedure is protected by the UBE retractor inserted through the obsilateral work portal. We insert the cage trial. Then we insert the cage through Zhang's portal. We can see the cage through the obsilateral side. Then we insert the second cage through the obsilateral side. The contralateral side cage and the obsilateral side cage. This is a double cage. A quarterback key portal can mark the midline during the UBE procedure and to protect the nerve root by the key valve, and the free assistant make them happy and make sure the cage in the midline. The location of the quarterback key portal in lumbar is we can draw a line in the disc space level and the medial margin of the spinal process. The cross point is the key portal. This is a ULIF case. I insert the key valve through the quarterback key portal, and the assistant use the UBE retractor to protect the nerve root. Then I insert the key valve to block the nerve root. Then I do not need the assistant. So the whole procedure is very easy. We insert the cage trowel and the protection of the key valve. Another portal is for the extiliff procedure, the quarterback portal. And for me, if I want to do the URBD in the extiliff case, I often choose the third portal to insert the big cage. It is the lateral margin is the first blue line, then about 2 centimeter, and the green line is in the disc space level. The cross point is for the big cage. Cervical UBE URBD by Zhang's portal. The location is similar to the lumbar Jones portal, but more above area, and I think it's very easy to do the decompression of the contralateral side laminar. This is a ipsilateral decompression area of the UBE URBD. The ipsilateral endoscopy portal and the work portal and the contralateral side the work portal. First, we expose the contralateral side laminar through the spinal process space, and then we build the Jones portal to remove the base part of the C5. Only removing the basement of the C5, we can see the contralateral side laminar of C5. You can see the surface of the contralateral laminar of C5. We did the contralateral side, the bone work through the third portal. It has a good angle to insert the instruments. We also can clear the soft tissue on the surface of the facet joint, the lateral mass of the contralateral side. We make thin the contralateral side of the C6 laminar. To separate the low margin of the contralateral flexible ligament. Then we do the bone work of the C5. Then to remove the flexible ligament through the third portal. is very easy and comfortable to insert the kerosene punch. If you choose the ipsilateral side work portal, you must choose maybe the curved kerosene punch. This is a contralateral side flare ligament. We remove the flare ligament until we see the V point. Yes, we can see the contralateral side facet joint. This is a facet joint. Then we finish the whole URBD decompression. The cervical quarterback key portal is also very useful when you do the keyhole procedure or remove the disc herniation. This is a C4 and C7 case. We insert the key wire as a protective retractor through the quarterback key portal. And then we use the knife to open the annular fibrosis. It's very safe. The third incision allows the tools to be placed at a more comfortable angle and make the decompression procedure to be more direct. Tight. We can only use two portals at the same time, which is technically a two-portal technique. Just like the shoulder arthroscopy, focus on the solving the patient's problem rather than focus on the number of the portal. Thank you for your attention.